Today I'm going to be presenting the results from a pilot study conducted here at the Rockefeller Neuroscience Institute and West Virginia University School of Medicine, investigating the safety and feasibility of focused ultrasound neuromodulation for substance use disorder. I have no financial conflicts to disclose. I receive funding support through the National Institute of General Medical Sciences, and I'd also like to acknowledge our collaborators on this pilot study, which is Insightech. To provide some background, many of us know that we are clearly facing an addiction epidemic currently. There's approximately 40 million individuals aged 12 or older had a substance use disorder in 2020, many of which involved alcohol and illicit drugs. 6.5 million individuals met criteria for both an alcohol and substance use disorder. Despite these very elevated numbers, a much smaller proportion of individuals received any form of substance use treatment, only 4 million individuals, and only 2.7 million of those received substance use treatment at a specialty facility. Drug overdose deaths were the highest in history this past year. Overdose deaths have quadrupled since 2000. Opioids are the main contributor to drug overdose deaths. Non-fatal overdoses with the availability of Narcan and reversal agents. It's estimated that there's approximately 800,000 non-fatal overdoses in the past year. And it's estimated that the opioid death toll will double by 2029. Here's a map just demonstrating across the nation the death rates. West Virginia, for the past several years, has unfortunately led the nation in overdose deaths. But this is clearly, an epidemic that's spread widespread throughout the nation and needs to be addressed. So, the opioid epidemic has gotten a lot of press and is talked about, but we can't overlook this very important complicating factor, which is polysubstance use. We know that here in clinic, individuals very rarely just use opioids. There's usually several other substances that they also use as well. We did a chart extraction from the medical records here in West Virginia, isolating individuals who provided a opioid positive urine toxicology, and then looked to see what other substances they were positive for. As you can see, there was a very large proportion of individuals who provided urine toxicology screens that were positive for opioids, plus at least one other substance. The most common substances that were also being used were cannabis and benzodiazepines. Stimulants, though, are on the rise. Methamphetamine, we've certainly seen an increase in methamphetamine use over the past several years. And just to highlight the concern also is with benzodiazepines, given the depressant effects of that drug, along with opioids, could also be contributing to opioid deaths. So the current opioid use disorder treatment here at West Virginia University, we have what we call the Comprehensive Opioid Addiction Treatment Program, or the COAT program for short. We currently treat over 600 patients in clinic, and we have 50 separate groups. It's a phase-based model, so the more success individuals have at remaining abstinent, they graduate to levels of care where they have to come into clinic less frequently. It's a recovery-focused biopsychosocial approach that is taken. It's group-based, where patients will receive medication management. They'll receive group therapy. They're required to attend mutual support groups in the community, such as AA and NA, and they also have individual therapy as well. As I mentioned previously, there's 4 phases. If individuals are struggling with with coming into the clinic weekly in what we call the beginner phase, there's higher levels of care, which include an intensive COAT program, where individuals will come in 3 times a week. And we also have residential treatment programs as well, if that's what they're in need of at the time. So when we look at adjunctive treatments such as focused ultrasound, This is really, it's not meant to replace the current treatments we have, but it's viewed more to augment, to be utilized as an adjunctive treatment for them. And team-based as well. We have physicians, nurse practitioners, therapists, case managers, so it's certainly a team approach that is taken with our COAT program here at WVU. A little background on why we selected the nucleus accumbens as the target for the focused ultrasound treatment. With the way that we conceptualize addiction is that acute opioid use results in a surge of dopamine in the reward circuitry, which then reinforces further use. Dopamine decreases over time, which then leads to increased substance use in an attempt to restore or increase that dopamine. That decreased dopamine also results in decreased activation of the prefrontal cortex, which also leads to poor decision making. And as a result, the nucleus accumbens becomes more active when it's seeking dopamine. And what we hypothesized, by targeting the nucleus accumbens with focused ultrasound, we'll then be able to increase dopamine, and by doing so, regulate dopamine, which should then lead to a decrease in substance use and substance craving. By increasing the dopamine throughout the reward circuitry, we want to approximate the individual's baseline state of dopamine before they started using substances. And then also, as I mentioned earlier, the frontal lobe activity, if we're able to increase dopamine within the nucleus accumbens, we'll hopefully then be able to modulate and activate dopamine within the frontal lobes as well, which should improve behavioral control. So the objectives of this clinical trial, the primary objective is to investigate low-intensity focused ultrasound as an adjunctive treatment for substance use disorder by assessing its safety and tolerability in subjects with opioid use disorder and co-occurring SUDs. And the secondary objective is to look at the effects of exablate ultrasound on substance craving. Here's our study design. Once patients were identified, we brought them in for the screening and baseline phase. If they were eligible, we then enrolled them to receive the focused ultrasound. They came in on the day of the treatment. They received a sham sonication where everything was conducted identically as it would be during the active. Only no energy was delivered. They then performed various intra-procedure assessments were completed. At that point, the active sonication was delivered. Again, the intra-procedure assessments were completed, and then they were monitored overnight, and we had follow-up visits on day 1, 1 week later on day 7, and then 3 months later on day 90. We looked at 2 different doses of low-intensity focused ultrasound. What we did first was we completed with 2 participants using a low dose. So it's what we consider to be not necessarily a therapeutic dose, but since this hasn't been looked at before for addiction in this target, the FDA required that we look at it with this lower dose first before moving on to what we refer to as an enhanced dose. So for the participants for the first 2 that received the low dose, we recruited them from one of the levels of COAT where they were more stable in treatment, because we wanted to ensure that we didn't lose them to follow-up, and we wanted to make sure that we got them through the 90-day follow-up. So we recruited individuals who were more stable. So they had less craving at baseline. Once again, they were more stable in treatment. And then for the group, the 2 individuals that we brought in that received the enhanced dose, these were individuals that were enrolled in weekly COAT. So they came in, once weekly. They had higher levels of craving. They had, more frequent, more recent relapses. So these 2 latter individuals that received the enhanced dose, those are the ones who we would think would benefit from this treatment in the future. So our outcome assessments, first and foremost, was safety and tolerability. And then the behavioral outcomes that we were looking at were substance craving. We assessed substance craving a few different ways. We looked at acute changes in cue-induced craving during the sham and active sonications. And then we looked at short-term changes in daily baseline craving. That was in the week before the treatment and also the week after. And then we wanted to look at more long-term changes in cue-induced craving 1 week following the LIFU procedure and then 90 days. So I mentioned we looked at cue-induced craving, a little more about that. So one of the ways that we get subjective reports of craving, we provide the individuals with the visual analog scale, or VAS, which basically is anchored at 0 equals no craving, 100 equals the most craving ever. And then we provide them with different cues. And after these cues, they answer questions. How much do you crave opioids right now? How much do you crave methamphetamine right now? Whatever their substance of choices are and whatever cues we're presenting to them, just to see if we're able to elicit a craving response by showing them the stimuli. So here's an example of how that goes. So these are when the neutral cues are being presented. As you can see, an example would be low craving. Then we provide them with drug cues, people using drugs, different types of paraphernalia, drugs themselves. And this gives us an idea of whether or not we're able to elicit that craving response by showing them this stimuli. So for the participant characteristics, first 2 subjects that received the low dose of ultrasound. First one was a 39-year-old male. Primary substances of choice were, prescription opioids and heroin, cannabis, and also used nicotine. The second subject was a 34-year-old male, also had a history of prescription opioid use and also a history of alcohol, stimulant, benzodiazepine, and nicotine use. The 2 individuals who received the enhanced LIFU dose, subject number 3, a 30-year-old male, history of multiple substances as well. And then the 4th subject was a 33-year-old female, had a history of opioid use disorder and also used several other substances as well. So first and foremost, as I mentioned, safety and tolerability. It was overall very well tolerated, minimal side effects. Side effects resolved very quickly, very transient for both the low dose and the high dose, or the enhanced dose of low intensity focused ultrasound. Substance craving. So looking at the acute within sonication session changes in cue-induced craving during both the sham and active sonications. So here on the y-axis, you can see these are the visual analog scale scores. I'll show first the individuals. We had 5 minutes of sham sonication, followed by 5 minutes of sham sonication to the right nucleus accumbens. So this is what we'd expect to see. Once again, all the procedures were the same. The only difference was that there was no energy delivered. And then once we went to administer the active sonication, you can see here we had a baseline, just as high as it was when it was sham, but then the craving for alcohol, benzos, and heroin all decreased significantly following 5 minutes and remained decreased. It came up here towards the end, but after we did 5 minutes, then we did 10 minutes of sonication to the left nucleus accumbens, and then another 10 minutes to the right nucleus accumbens. So we did show that we were able to acutely modulate the craving response for this subject. The 4th participant, once again, there's a bit of a sham response here. Craving decreased a bit. We were able to, once the active sonication, we were able to get the craving back up, especially for cocaine and alcohol. And as you can see here, once again, there's a trend towards decreasing after 5 and 10 minutes of sonication to the left nucleus accumbens, and then a further decrease following an additional 10 minutes of sonication to the right nucleus accumbens. So I think that this, at the very least, shows that we're able to modulate the craving response acutely. Then we wanted to look at the short-term changes in daily baseline craving. So this is, they completed a ecological and momentary assessment on their smartphone. They were asked questions about craving every day for the week before and then the week after. So this is the 3rd subject. So looking at the daily craving ratings, you can see here, it's on a scale of, if you look at the y-axis, scale of 0 to 10. seeing decreases for heroin, for methamphetamine, cocaine, benzos, alcohol, and also nicotine. So definitely seeing changes in the week following the ultrasound treatment. And participant number 4, well, daily craving ratings were much lower at baseline. She didn't tend to crave when not exposed to the cues. Regardless, though, in the week after, really most of her substances were down to 0. Nicotine also craving was significantly reduced as well. So it shows that there might be some short-term effects that are produced. And finally, we wanted to also get a sense of possible long-term changes in cue-induced craving. So we did the cue reactivity task at baseline during screening, and then also 1 week after the treatment and 3 months after the treatment. So this is the data from participant number 3. So you can see here at day 90 relative to day 7 and the baseline before the sonication, we did see some decreases for several substances. Same for the 4th participant, cue-induced craving reduced for several, decreased for several different substances as well. So, we can't say with absolute confidence, since this wasn't randomized, since we didn't have a true sham control where, there was just a purely sham arm. But it does show that this warrants some follow-up and additional studies. So in summary, 4 out of the 4 subjects who were enrolled successfully completed the procedure. There was a positive safety profile. There were no severe and or unresolved adverse events. We were able to acutely reduce substance craving during the procedure, and LIFU may also have prolonged effects on substance craving. Future directions: we'd like to initiate a larger trial with a larger cohort of participants, look into various LIFU doses and possibly different targets as well, and then investigate other factors which are associated with relapse, such as cognitive functioning. And thank you for the opportunity to present today.